Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 385 of our pharmacotherapy series, which majors in pain and its management. The first question in this case reads, LOV is a 58-year-old man who was diagnosed with stage 4 squamous cell carcinoma of the subglottis 2 months ago. The cancer is locally advanced with involvement of multiple cervical lymph nodes. He had a modified neck resection to remove the primary tumor and lymph nodes while sparing the larynx. Chemoradiation therapy began 3 weeks after surgery with cisplatin dosed at 100 mg per meter squared every 3 weeks, days 1, 22, and 43, and external beam radiation delivering 70 GY fractionated over the course of 7 weeks. LOV is now in his 4th week of radiation therapy and continues to have significant neck and shoulder pain described as sudden shock-like sensations with movement, and rated 6 out of 10 despite a recent increase in his oral extended-release morphine to 60 mg twice daily with immediate-release morphine 15 mg orally every 4 hours as needed for breakthrough pain. He also reports that his throat is getting so sore that he cannot bear to swallow and rates the pain 10 out of 10. LOV appears quite fatigued and lethargic during his appointment with the radiation oncologist. The physical examination is remarkable for dry oral mucous membranes, erythema and mild ulceration of the oropharynx, and allodynia with light palpitation of the trapezius and sternocleidomastoid muscles with pain greater on the left side. The radiation oncologist orders laboratory tests and the results are as follows. General chemistry results include sodium levels of 132 milliequivalents per liter, potassium levels of 4.2 milliequivalents per liter, chloride levels of 101 milliequivalents per liter, bicarbonate of 26 millimoles per liter, anion gap, 5 milliequivalents per liter glucose, random of 70 mg per deciliter urea, nitrogen of 28 mg per deciliter, creatinine of 1.5 mg per deciliter, calcium, total of 9.0 mg per deciliter. His CBC with differential results are as follows. White blood cell count, 7.1 times 10 power 9 per microliter. Red blood cell count, 3.25 times 10 power 6 per microliter. Hemoglobin of 14 grams per deciliter. A hematocrit of 43%. Mean cell volume of 91 times 10 power 6 per microliter. Mean cell hemoglobin, 30 picograms per cell. Mean cell hemoglobin concentration, 33 grams per deciliter. Platelet, 369 times 10 power 3 per microliter. Absolute neutrophils, 5 times 10 power 9 per liter. Absolute lymphocytes, 1.2 times 10 power 9 per liter. Absolute monocytes, 0.2 times 10 power 9 per liter. Absolute eosinophils, 0 times 10 power 9 per liter. Absolute basophils, 0 times 10 power 9 per liter. The radiation oncologist decides to admit LOV to the hospital for dehydration and pain management. So my question to you is, what are the possible etiologies of LOV's pain? LOV is presenting with a new complaint of a severe sore throat and persistent neck and shoulder pain. Laboratory data ruled out infection and myelosuppression. His kidney function may be impaired by dehydration and cisplatin therapy. The most likely causes of LOV's pain are the recent surgical neck resection and mucositis from external beam radiation. LOV also has postoperative peripheral neuropathy characterized by shock-like sensation in the neck and shoulders after the resection of the tumor. The physical examination of LOV's neck and shoulders is remarkable for allodynia, which can be present with neuropathy. The cervical lymph node resection may have caused neuropathy due to nerve damage via crushing, pressure, incision, or inflammation. This results in ectopic firing and changes in the receptive field causing nerve excitability and spontaneous activity, e.g., wind-up. Neuronal hyperexcitability may be related to overexpression of sodium channels and activation of the NMDA receptor. Cervical plexopathy may also be contributing to the discomfort. Mucositis occurs in up to 45% of individuals treated for head and neck cancer with the chemoradiation regimen LOV is receiving. Chemotherapy and radiation directly affect the proliferation of epithelial cells and connective tissue, causing damage to and loss of the mucosal barrier. On physical examination, the oropharynx is red and ulcerated, which is indicative of mucositis. Pain associated with mucositis is dependent on the degree of tissue damage, sensitization of nociceptors, and activation of inflammatory and pain mediators. LOV's complaint of sore throat pain limiting his ability to swallow is a common presentation of mucositis. In head and neck cancer patients treated with radiation, pain intensity scores directly correspond to mucositis and increase at week 3, often peak at week 5, and persist for weeks after the end of treatment. In addition, LOV may have cisplatin-related neurotoxicity. Approximately 30% to 40% of patients may experience sensory loss as a result of direct neuronal DNA damage and apoptotic cell death caused by cisplatin. Neurotoxicity is a dose-limiting side effect for all the platinum agents. Cisplatin peripheral toxicity can occur in patients who receive a cumulative dose of more than 400 to 500 mg per meter squared. All sensory modalities are involved, but loss of large fiber function is often prominent. Persistent dysesthetic pain, i.e., an unpleasant abnormal sensation, whether spontaneous or evoked, is a late phenomenon that may continue to progress for several months after cessation of cisplatin. LOV was started on intravenous hydromorphone using patient-controlled analgesia, abbreviated as PCA, with an average usage of 14 mg per day. He now rates his pain as 4 out of 10. Owing to difficulty swallowing secondary to the mucositis and xerostomia, he had a gastric feeding tube placed for nutrition. The plan is to convert the intravenous hydromorphone to a transdermal fentanyl patch. So my next question to you reads: what transdermal fentanyl patch dose should LOV be started on, and what are the instructions for use? Let's briefly talk about transdermal fentanyl dose calculation. Historically, the World Health Organization analgesic ladder has been used to guide cancer pain management. The downside to using this algorithm is that cancer pain rarely progresses in the stepwise fashion that the WHO ladder implies. Therefore, several organizations including the American Pain Society and National Comprehensive Cancer Network have proposed different strategies for managing cancer pain based on the assessment of the patient, development of an individualized care plan for pain, and symptom management. Before starting intravenous hydromorphone, LOV has severe throat pain rated 10 out of 10 and moderate to severe neck and shoulder pain rated 6 out of 10. Because of the severity of pain and inability to swallow, intravenous opioid therapy using patient-controlled analgesia is appropriate. Hydromorphone is a good choice for intravenous opioid therapy because it does not have active metabolites that could accumulate with renal insufficiency. The transdermal fentanyl patch is an excellent choice for LOV's eventual outpatient pain management because it will provide continuous release of opioid and is convenient to use. Cadian, an extended-release morphine capsule, can be administered via a 16 French gastrostomy tube because the capsule can be opened and contents flushed through the feeding tube with water. Limitations to the use of this formulation in LOV include the need for patient manipulation of the gastric feeding tube with self-administration and the potential for morphine side effects secondary to metabolite accumulation if renal insufficiency persists. Transdermal fentanyl patches are intended for opioid-tolerant patients with stable chronic pain. Opioid-tolerant patients are those who have been taking daily, for a week or longer, at least 60 mg of oral morphine, 30 mg of oral oxycodone, or at least 8 mg of oral hydromorphone or an equianalgesic dose of another opioid. Respiratory depression associated with opioids is more likely to occur in opioid-naive patients, patients with postoperative pain, and those with intermittent or mild pain that is managed with as-needed opioid administration. Before the current hospital admission, LOV was taking 120 mg of extended-release morphine per day with additional oral immediate-release morphine for breakthrough pain. Therefore, LOV is a good candidate for a transdermal fentanyl patch. LOV's transdermal fentanyl regimen will need to be determined by converting intravenous hydromorphone using an equianalgesic dose approximation. Doses of two different opioids, or two different routes of administration of the same opioid, are considered to be equianalgesic if they provide the same degree of pain relief. Provides equianalgesic opioid doses. There are several published tables for converting morphine to transdermal fentanyl that have been developed by researchers and manufacturers of transdermal fentanyl products. They provide slightly different dose conversion recommendations. Duragesic has wide morphine dose ranges, which may result in underdosing the transdermal fentanyl patch in cancer patients. Breitbart and colleagues recommend a 2-to-1 ratio of oral morphine to transdermal fentanyl, i.e., 2 mg oral morphine per day is equivalent to 1 microgram per hour transdermal fentanyl, resulting in higher transdermal fentanyl doses, which may be excessive for elderly patients. A study by Donner and colleagues suggested a dose ratio of 60 mg per day oral morphine is equal to 25 micrograms per hour transdermal fentanyl, which falls between the manufacturer's table and the study recommendations by Breitbart and colleagues. The Donner conversion ratio is used in most references because it is less likely to cause underdosing or overdosing. LOV's transdermal fentanyl patch dose is 116 mcg per hour using the dose ratio 60 mg per day oral morphine to 25 micrograms per hour transdermal fentanyl. Because LOV's pain is well controlled based on the intensity rating of 4 out of 10, the dose of transdermal fentanyl should be rounded down to the nearest available patch size, which is 100 micrograms per hour. If LOV's pain was not controlled, the transdermal patch dose should be rounded up to the nearest available patch size. Patients who have been on opioid therapy for a prolonged time are likely to exhibit tolerance to the therapeutic effect. However, when switched to a different opioid, the level of tolerance may change, i.e., diminished tolerance to the new opioid, owing to the pharmacokinetic properties of the new opioid. This change in sensitivity to the new opioid is called incomplete cross-tolerance. Most opioid doses need to be reduced by 25% to 50% after the conversion calculation to account for the incomplete cross-tolerance. The exception to this is methadone and fentanyl. Conversion ratios for methadone and fentanyl have already accounted for incomplete cross-tolerance, so no further reductions are generally needed. Therefore, LOV's transdermal fentanyl patch dose should not be reduced for incomplete cross-tolerance. After the initial transdermal patch is applied, it will take 12 hours to reach the minimal effective blood concentration and up to 36 hours to achieve the maximal concentration. The transdermal fentanyl patch must be changed every 72 hours to maintain the steady-state blood concentration. Elderly, cachectic, or debilitated patients may have altered pharmacokinetics, i.e., more rapid rate of release, as a result of poor subcutaneous fat stores, thus requiring the transdermal fentanyl patch be changed every 48 hours. LOV should be instructed that the transdermal fentanyl patch should be applied to an intact, non-irritated and non-irradiated flat skin surface such as the chest, back, flank, or upper arm. He should be warned about the risk of elevated body temperature, e.g., 40 degrees Celsius or 104 degrees Fahrenheit, resulting in a faster release of fentanyl from the patch. The increased fentanyl level could cause serious respiratory depression. LOV should be cautioned about avoiding external heating sources such as electric blankets, heating pads, tanning beds, sunbathing, hot baths, hot tubs, saunas, and heated water beds. Fentanyl transdermal skin patches should not be used if damaged or cut because this may increase the absorption of the medication. LOV should be told to wash his hands immediately if contact is made with the fentanyl gel that was inside the transdermal patch. My next question to you reads: how should LOV be transitioned from IV hydromorphone to the transdermal fentanyl patch? Regarding transition to transdermal fentanyl, reducing the intravenous hydromorphone continuous infusion by 50% should occur 6 hours after the initial transdermal fentanyl patch is placed. Discontinuation of the IV hydromorphone continuous infusion and patient-controlled analgesia dose should occur 12 hours after the initial transdermal fentanyl patch placement. LOV may need to use a short-acting, i.e., immediate-release, opioid until the maximal fentanyl blood concentration is achieved. Additional short-acting opioid may be needed for pain that occurs near the end of the 72-hour dose interval. The next question reads, what are LOV's options for breakthrough pain management? Let's discuss opioid therapy for breakthrough pain management. Breakthrough pain can be classified as spontaneous pain, i.e., frequently idiopathic, occurring with no known stimulus; incident pain, i.e., secondary to a stimulus that the patient may or may not be able to control; or end-of-dose failure, i.e., pain at the end of the dosing interval of the extended-release or long-acting opioid. Incident pain can be reduced by instructing the patient to take a dose of short-acting opioid 30 minutes before activity. Spontaneous breakthrough pain should be treated by administering a short-acting opioid as soon as the pain is experienced. For patients on extended-release or long-acting opioid formulations experiencing end-of-dose failure, APS guidelines recommend supplementary doses of a short-acting opioid equivalent to 5% to 15% of the total daily dose to be taken every 2 hours as needed. Short-acting opioid co-formulated with acetaminophen products have a maximal dose to prevent liver toxicity with acetaminophen, thus creating a ceiling limit on the analgesic efficacy. Plain short-acting opioids, e.g., morphine, oxycodone, or hydromorphone, should be used for patients requiring large doses for breakthrough pain. In LOV's case, a short-acting opioid solution should be available for breakthrough pain before discontinuation of intravenous hydromorphone. The short-acting opioid can be administered in solution form through the gastric feeding tube or as oral tablets if LOV can tolerate swallowing. LOV's oncologist would like to use oral morphine solution for breakthrough pain management. Because the transdermal fentanyl total daily dose is approximately equal to a total daily dose of 280 mg of oral morphine, 10% of the total daily morphine dose would be 28 mg. The dose should be rounded to the nearest tablet size for a short-acting formulation, which is 30 mg, if LOV would eventually take morphine tablets. If more than 2 supplemental doses of short-acting morphine 30 mg are required daily to keep LOV's pain under control, an increase in the transdermal fentanyl patch dose should be considered. Moderate to severe pain may require an increase in the opioid total daily dose by 50% to 100%. Fentanyl administration by oral and intranasal transmucosal routes is approved for breakthrough pain management in cancer patients. The dose of both formulations is determined by titration, i.e., starting with the lowest dose and increasing based on pain relief, rather than a percentage of the total daily dose. The oral transmucosal route would not be preferred in LOV's case due to his dry oral mucous membranes secondary to radiation, which will impact absorption. Xerostomia is a common problem associated with radiation therapy of the head and neck and occurs in 80% of patients by week 7 of treatment. Problems related to xerostomia include difficulty speaking, chewing, swallowing, infections, mouth pain, and dental caries. Reports indicate up to 64% of patients may experience moderate to severe xerostomia 3 years after radiation treatment. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 386.